Thank you, Jim. Can everybody hear me? All right. I've given talks in this room before, and I can never kind of figure out why people need to sit far away from me. I promise you, I won't ask you any questions. Those cluster of folks sitting up in the back corner as far away from the podium as possible. And maybe it's because you feel like you might want to leave in the middle. And if anybody has an urge to leave, please do. I won't be insulted. Otherwise, feel free to come closer and we can have sort of a more intimate conversation. For those of you that haven't been to any of the Autism 200 series, we're teleconferencing this around the state and Alaska, I think. Is that right? Going to Alaska. So folks on the other end of the television sets, at some point will have an opportunity to kind of join our conversation here. So if you hear some strange noises coming out of the microphone, it may be because some folks in Wenatchee have signed on and didn't mute their microphones or something like that. I am going to quiz you a little bit before we get started and ask anybody that can tell me the name of the child that drew this picture here. Shout it out. It's not Picasso. That's the standard answer. Come on, take a look at it. Keep looking at it. John, who said that? All right, you win a prize because most people can't figure it out. Can everybody see where the John is spelled in his face? The J, O, H, and N there. So John drew this picture when he was about 4 and a half, 5 years old. And what's interesting about this picture is the combination of letters, which, as we know, with kids that are autistic children often are very interested in letters and numbers, and faces. And kids with autism are also interested in faces, but in ways that sometimes are different than many of the rest of us. Before I go any further, I'd just be interested to know who I'm talking to. So first, anyone that is a parent of a child with autism, please let me know. Okay, and teachers, therapists, speech, physical, occupational kind of therapists. Distant family members are just curious people that happened to wander into this when they were lost somewhere at Children's Hospital. Nurses, medical professionals, physicians, and who did I leave out? Did I leave any of you out? Again, there's this group over here. I don't know what they're all about, but they're all friends because they're all sitting next to each other, which is really nice. You want to tell us who you are?
Behavior specialist.
Behavior specialist. Excellent. Like ABA folk and that. Yep. Behavior analyst. Excellent. Excellent. I'm sorry I didn't mention you. Well, I guess the only reason why I'm bringing that up is that we may at some point have a conversation with each other, and it's kind of useful to know where different people are coming from as we kind of explore some issues. So. Here is the relative agenda that we're going to talk about today. Yes. I'm going to try and review some new interesting issues in diagnosis and epidemiology. Epidemiology means trying to understand the prevalence of this disorder and how that's changed over the years and what that might mean. I'm a physician. I'm going to bore you with some science, I think, or hopefully not bore you with some science. We're going to talk a little bit about the state of services in our state and a little bit about treatment. And then we're going to hopefully have a lot of time for questions and discussion because the topic of autism is a huge one. This morning, our group of physicians in the neurodevelopmental program have a weekly rounds. And I was speaking this morning to our group of colleagues, sharing with them what's new in the world of research about autism. And it's an enormous subject. So we're barely going to touch on a whole bunch of very interesting things, but I'm open to talking about all of those. So First, some quick words about what is autism. I'm assuming that many of you already know that. This is another kind of interesting drawing of a child, the child did, because this picture is called silent F, as I'm sure you can see. And the face is a letter F. Wearing a hat, having arms, neck, feet, nice shoes there. So it's another example of the curious phenomena of putting letters and faces together. Jim? Oh, if any of the distant sites haven't muted their mics, are you hearing a buzz or something? Yeah. Sorry, I'm talking and not listening. So, any of you distant sites, please try to mute your microphone. That would be great. So, a quick word about definitions of autism, which are going to continue to change as we move forward. By the way, not all of these slides are in your handout, so please don't feel confused about some missing slides. Mostly things with pictures are not necessarily in the handout. But in the past, autism has been defined by having difficulties, developmental difficulties in 3 areas of development: communication, social behavior, and a tendency to do things over and over again, or what's been called restrictive and repetitive interest. Also, to some extent, though not defined in the disorder, sensory behaviors or strange sensory behaviors are often a part of what we see in individuals with autism. What we mean by that is that sensory includes things like smell and touch and sight and hearing, and our brain receives all of this information from all of our sensory organs all the time, constantly. If you want, you can focus your attention on what your big toe on your right foot feels like and feel it. But whether you were paying attention to what your big toe on your right foot was feeling before I asked you to do that, or that buzz, everybody hear that buzz? It's there. Were you hearing it? And were we all hearing it at the same level? Nobody knows, because nobody can tell you what you're feeling like, what I'm feeling like, what I'm seeing. That process of being able to discriminate sensory information from one microsecond to another, paying attention to what your leg feels like, or what your smell organ is sensing, or what your ears are hearing, is regulated in our brains from microsecond to microsecond. And some people feel those things at different levels. Imagine what it would be like if you were feeling all of your senses at the same level all the time. Be a very confusing world, because you couldn't tell what to pay attention to. But our brain is feeling those things and sensing those things and aware at different levels. So people with autism seem to have some problems processing or adjusting or modulating sensory information. And if you have all of those things, then you might be said to have autism. But there are many other terminologies. Whoa! Somebody hasn't muted their microphone.
Please mute your microphone, whoever just joined.
Sorry about that, folks. So as we can imagine, if you have sort of all of these things, then we might reasonably say that you fit the diagnosis or the definition of autism. But people don't. Everybody isn't the same. And so if one of the ways of looking at it is that if you have social impairments and restricted and repetitive interests, but less communication impairment, then somebody might categorize you as having Asperger's. If most of your problems are in restrictive and repetitive interests, then someone might... that's one of the dilemmas of doing teleconferencing. Might have obsessive compulsive disorder, or social phobia, or developmental language disorders. And we don't know how to really, we meaning the scientific community to understand, that tries to study autism, has trouble with this terminology because there's not agreement about what these terms mean. And another thing to understand about autism, in the past we've defined autism in 3 subcategories: autism, PDD-NOS, which stands for pervasive developmental disorder not otherwise specified, and I can say that very fast now, and Asperger's syndrome. And what we know about these things is that these categories change with age. So that when you often see young children who are not talking, for instance, when they're very young, they might receive a diagnosis of autism, but as you see them getting older and older, their categories may change. Those of you that read the New York Times, there was an article today or yesterday about a new study that describes a population of children who have, quote, lost their autism diagnosis. Used to have autism, don't have autism. One can imagine kind of sliding off this curve somewhere, and we can talk about the reasons why that might be. So we're redefining autism with a new set of guidelines called the DSM-V. DSM stands for Diagnostic and Statistical Manual. It's the way that the mental health community defines conditions like depression or anxiety or schizophrenia or autism or other developmental problems. And the new version of the DSM-5, the new version of the DSM, which is replacing the current DSM-4, has recognized that we're not able to distinguish what is social behavior and what is a communication behavior, because they're intimately linked in human beings. And so those separate circles are being combined into one. The old way of defining the condition did not attempt to figure out severity. Severity is a key issue. The rule of thumb in autism is when you've met one autistic person, you've met one autistic person, and the next person is going to be very different. And we don't have language to describe those differences or define what it means to be more severe or less severe in these different domains. The subtype definitions continue to drive everyone crazy in the field, because you can line up 100 specialists and show them one person, and you're going to get very different answers, and I'll show you that in a minute, about which subcategory it exists. So the subcategory names are disappearing in this new definition of the condition. And that's actually been a problem for a number of folks, because at least to some extent for the Asperger community, Asperger's syndrome is not a disorder, it's an identity. An identity that some people are very proud to say, I'm an Aspie, I have Asperger's syndrome, which is a really important and different way to frame the problem. Rather than saying there's something wrong, they're saying there's something right about being this way. They're different like all of us are different, and acknowledging differences and treasuring them is very important. So there is concern in that community that by eliminating the name, somehow we're eliminating their identity. An important notion and something that we're going to continue to struggle with. So the DSM-5 is going to do away with subdomains or subtypes, and going to add severity measures. And what is nice about the definition of severity is not being described on things that you can and can't do, but how much support you need. And so that's taking into consideration, what's your community like? There's two people, one in a community that's very supportive and another in a community that has no support, will look very different in terms of their severity. So that's recognizing that we exist in a community. a community of support, whether that's parents or relatives or teachers or therapists, and the degree that you are functioning has to do with how much support you get or need. DSM-5 will not change the diagnosis of individuals already diagnosed. This is a prospective definition. That is that when the DSM-5 gets published in May of this year, and we're moving forward in terms of using that as our guideline to define the condition, it will be into the future and not looking back. So those families that have been worried that the new definition is going to eliminate services for them is unfounded. That's not going to happen. We're not going to be looking back. We're going to be looking forward with this new definition. And like all definitions in healthcare, this is very much a work in progress. There's no condition in known to man that there isn't constant revision and re-understanding, whether we're talking about breast cancer or diabetes or heart disease or anything else. So new terminology keeps happening. So graphically, and I'll do this a few times because I'm very proud that I could pull this off. It does that. Want to see it again? Okay. There we go. Enough. So instead of talking about a triad, we're talking about a dyad of domains, or a way to describe a domain is a set of behaviors that have to do with, for instance, communication. Despite the new guidelines, there's a lot of disagreement about diagnosis. And I'll demonstrate that in a second. So in June this year, we at Children's with the University of Washington and a statewide organization known as the Washington Autism Advisory Council put together a meeting here in this auditorium to explore the dilemma of diversity of opinion about diagnosis. And the way the conference went was that there were 90 people in the audience. Everybody was asked to bring along a laptop or some kind of device to access the internet. And we queried the audience repeatedly as we showed them different cases, asking their opinion. And in the audience were speech therapists and psychiatrists and neurologists and psychologists and educators and a whole lot of different folks. So we had a pretty diverse audience of people that called themselves somewhat experts, or at least very familiar with what is autism. And here's what we learned from doing that. Nobody can agree. So this is one of the three cases, and the final question in the survey was, do you think this child has autism, yes or no? Got to commit yourself. You got to write it down on the bottom line. That's the way it's going to be, because you're responsible for giving a label to this person. And as we can see, it's kind of all over the map. There was no consistency. The nurse practitioners looked like this. Developmental pediatricians were just the opposite. Educators were like this. Neurologists were like this. What is that category? Other category. PSC was psychiatrists. This was psychologists. This was speech therapists. Perhaps the dominant opinion, if you kind of looked across, was that that particular case did not have autism. But there was an agreement. And there wasn't even agreement within specialties. So what does that say about how correct we are when we make diagnoses? It's unfortunate. Now, these were particularly difficult cases. These weren't typical situations. These were the hard cases that we chose intentionally, the ones that were confusing to us as clinicians. When we did it on another case, we saw the same thing, and repeatedly, and we're still analyzing this data, we saw this imbalance, this disagreement about what an individual child had. And these were kids we had videotapes of them, questionnaires from their families, interviews, all that kind of information. Same kind of thing that we as clinicians would go about trying to figure it out. So the bottom line message is that this definition keeps evolving and changing, creates confusion for us as professionals, for families as well, and that many times we end up saying, I'm not sure what the diagnosis is. And that can be very uncomfortable. People want to know, but the state of the art is that we can't answer that in many cases. Certainly not in all, but in many cases. So the diagnosis is based on observation. Not, as I said, not all fit into a category. They're confusing kids. And so given that, what is important for everyone that relates to this problem, whether it's family members or professionals, that what's really important is helping the child to achieve their highest level of capability. And identifying strengths and weaknesses rather than focusing on labels and diagnosis is ultimately the best way to deal with it. Unfortunately, we live in a world that requires forms to be filled out and check boxes, and somebody has to write a name down and stuff. But we shouldn't forget that those labels may be wrong, may change over time, are artificial, are not agreed upon, but nevertheless, we can still understand what the problems are that an individual might have. So now we're going to talk about how that relates to the issue of epidemiology. Epidemiology is the science of counting things. And so one of the child artists that I'm most fond of drew this picture. And what's interesting about this picture, well, first of all, he drew this picture on a computer with a mouse at about 4.5 years of age. So he's an extraordinary artist. Everybody would say he's an extraordinary artist. And he made numbers into people. So we had another artist that made faces out of letters. Letters and numbers are the same thing. Why are letters and numbers interesting to autistic kids? Because they're very concrete. A 1 is a 1 is a 1. An A is an A. There's no subtlety, there's no ambiguity about what they are. And so it may be because children and adults that have autism have trouble with abstract kind of concepts. This is very appealing. It's very easy to understand that. But nevertheless, this child made that letter into a person. So I don't know what that means, but I thought it was interesting and also quite extraordinary art. So I want to say a little bit about prevalence and that terminology. Prevalence is the total number of cases in a population at a specific time, and you can express those numbers differently. So people get a little confused when they see numbers like 1 in 88, which is the current considered prevalence of autism in the United States. The previous prevalence was described as 1 in 110, which is the same as, if you do the math, as 0.9%. All of these numbers kind of cluster around 1%. So in this audience right now, the prevalence of males is 45%, I guess. So is that clear what that means, what that number means? It's a number of X, in this case males, out of a total population. So let's look at what's happened to the prevalence of autism over a period of time, starting in 1966, when some of the first studies were done, up until 2009, when this graph shows. And you can see the numbers. The blue line is total autism cases, or prevalence. It's prevalence per 10,000. The subcategory autism and the subcategory of Asperger's and PDD-NOS. And different studies over time have used different ways to segregate that population. Probably the best line to look at is this blue line. And so it is not surprising that someone would say there must be an epidemic of autism occurring. It's an astounding increase in prevalence over a pretty short period of time. Here's another graph. This includes a study that was done in South Korea where the prevalence is about 2.5 times that of the US. So instead of 90 or 100 per 10,000, that's about 1%, they're counting 260 or 70 per 10,000 in a community in South Korea. And so when we go back and add the latest numbers for the US, the Center for Disease Control numbers, where the number looks something like 110 per 10,000, that's what that graph is. So we're struggling with trying to understand, what does that mean? Why is this occurring? And there are many explanations and no agreement. So I just want to show you a little bit about the problem of counting and how hard it is to count. So this comes from the report that announced the rate of autism in the US was 1 in 88 or 1.1% or 110 per 10,000. Those numbers mean the same thing. And what's important about this is to show you how varied it is. If you live in Alabama, nobody has autism. If you live in Utah, everybody has autism. And then some of these things cluster around this rate here. But the size of these circles also relate to the population size that was studied. And in some cases, the population size, like in Utah, where they tried to get this estimate, was very low. So they're making assumptions based on looking at a very few kids. And the way the Center for Disease Control did this study was that they looked at educational records and health records, and then had a checklist of symptoms that they went through and reviewed as they looked at each set of information and said, yes, no, yes, no. In fact, as they did the study, they often discovered children who had not had a diagnosis but met the CDC's definition, and vice versa. And so the Center for Disease Control has been doing the same kind of approach now 3 times, and each time comes up with a higher number. And so that's a very troubling number for us all. What does it mean to keep identifying more and more patients? And there are many explanations. Maybe I'll have a chance to share some of the ideas why that might be. So here's the Korean study. The study was done in these years in a relatively small community in South Korea between these years. And the population was born in these years. These were 7 to 12-year-olds. They looked at populations of children in special education and then looked in the entire general population. And what they discovered was that more of the kids that got identified with their criteria, same criteria we use, in the general education category, who had not been identified as having something different than in the special education category. And so what this might mean is that, this is a detail I don't think we have to get into, but what that might mean is that, that even now there are populations that are not being diagnosed, that are being somehow missed or called something else, may not have access to services. On the other hand, this also says that the public health issue, the prevalence that we're needing to deal with, is 2.5 times what we think it is now. And as we all know, there are not enough teachers, therapists, et cetera, to deal with that. So the real prevalence may be somewhere between those two numbers. We don't know. If that's the correct number, we're going to keep, every time the Center for Disease Control does this, that number is going to keep climbing. That's because more people have been identified. Doesn't mean that there are more there. Or does it? I don't think we know. So here's another piece of information that's very interesting and confusing. So in Great Britain in 2007, they did a survey trying to identify how many adults have autism using the same criteria that we use now. It was a very big study. They interviewed 13,000 households. They identified this number of cooperating adults. They sent a screening questionnaire to identify possible autism. Eligible phase 2 adults, 5,000 were identified as possibly having autism. This number agreed to have a clinical interview, and then they did a great many tests. ADOS is a very complicated test, takes a long time, and they did ADOS testing on 630 adults, which was a sample of that whole population. And lo and behold, the prevalence of autism in adults age range from mid-20s up to 70 was the same prevalence as we now think exists in children, 1%. So if the prevalence of autism is 1% in adults, then maybe it's been here all along, and we didn't call it that. Nobody's done this study again. Nobody's tried to try and count prevalence of autism in adults. So rather than think about this as a rising tide, as an epidemic, it may just be that we've never identified it before. And we don't know. I think I said that already. And the reason why this is important is that there's a lot of concern on the internet, patients, that somehow something has caused all this autism to occur. As you know, if you read about it, there's a lot of blame on vaccines causing autism. I can tell you that there's zillion studies trying to blame something else. So these are called association studies. And these studies are often misleading. But here are the things that have been reported in the medical literature as causing autism. Rainfall, more autism where it rains more, the order that you have children, whether your mother had diabetes, whether during pregnancy mother took an antidepressant, prematurity, cerebral palsy, age of parents, use of cell phones, my favorite topic. There is a report about the association between cell phones and autism, living near freeways. And if you use that association logic, picking some fact like the frequency of cell phone use, and trying to attribute to that a causation, you're likely to come up with some very, very poor information. So this is a graph of mercury exposure in vaccines and the prevalence of autism. And obviously, from this graph, you would assume that mercury causes autism. So you have to be careful in looking at these kind of information. They tend not to be correct, especially if you don't know how the study was done or how the data was acquired, and the assumption that the two are related. If you actually were to plot out the number of cell phones in the United States with the autism graph, they would match each other. And therefore, obviously, cell phones cause autism, right? Yeah, everybody says yes. So you've got to kind of figure this out. By the way, there isn't mercury in vaccines in the US anymore. But there's also absolutely no evidence that mercury caused autism, especially if it's always been there. So what are we going to make about this? Maybe it's always been there, and the prevalence in adults is the same as children. for the last 50 years, 70 years. Don't know. We think that genes are very important, and there's a lot of new research about genetic causes. Maybe by understanding the genetic stuff, and I'm not going to talk too much about genetics, it's a very complicated topic, but if there are questions, we can move on to it. But by trying to understand genes, we're going to understand how cells work, how brains develop, how pathways get developed, and maybe going to help us develop some medications that treat more effectively problems in autism. That's already happening. Maybe the environment, is important. That's where all those questions about living close to freeways or exposure to rain or cell phone exposure, maybe those are important issues. Maybe because we live in a more toxic environment, we know that there are a lot of toxins. That can help explain why there's more autism. Nobody knows. Depending on how broad the autism definition, the more cases you find. So if we don't agree, even with the DSM-V, we don't agree what is autism. Community of specialists don't agree what autism is. We're in a real dilemma in trying to figure this out. And one of my friends' favorite phrases from Mark Twain is, there are lies, damn lies, and statistics. So you have to be careful when you look at statistics. You have to understand how they were created and what they mean, and not assume that number that pops up is actually correct or is a correct interpretation. So we're going to do a little serious science now. This is a graph of the number of published articles about autism in these years. And as you can see, that's a very rapidly rising curve. This may make a loud noise all of a sudden, so I'm going to see if I can avoid that. So I'm going to show you some movies in a minute with some audio with them. Excuse me. All right. Sorry for that. So what this graph says is that there's a lot of research money looking at autism. It's a very intriguing scientific topic. A lot more people are studying it from many, many points of view. That's good news. Autism is beginning to get the kind of scientific attention that 15 years ago cancer had in heart disease. And when that scientific energy is directed at a condition, a lot of progress has been made. The rate of heart disease in the US has declined precipitously, certainly deaths from cardiac disease to a large extent because of research that was done 25 years ago. Cancer is the most common cancer in childhood is leukemia. When I was a pediatric resident back in the day, every child who had leukemia died, 100% fatal. Now, typically a typical outcome for a 4-year-old with acute lymphoblastic leukemia is about 90% cure. That took a long time, that's 40 years. But it didn't happen because people just kind of ignored the topic. It took a lot of dollars, a lot of time, a lot of research. And we're beginning to see that slowly paying off in terms of understanding about autism. So I'm gonna back up a second. Close your eyes now, because it's gonna look nasty here. While we try and crank up something else. Everybody see that? So what is that? That is a cell under a microscope. It turns out to be a neuron in a petri dish. And the interesting story is how that cell got to be in that petri dish. If you were looking at a cardiac cell, a heart cell, it would look somewhat similar to that. It's kind of intrinsically moving. And in this case, what that movie is showing is the influx of calcium ions into and out of the cell. So Richard Dolmetsch is a neuroscientist at Stanford. And he has been studying a condition called Timothy syndrome. Ricardo has an autistic son, and that's probably part of the reason why he got involved with it. But he's really interested in calcium channels. That's what he loves to think about. And what the current level of science is able to do is take a skin sample from a patient with Timothy syndrome, little biopsy, take out some of the cells, grow them in culture, turn them into stem cells, convert skin cells to stem cells, and then change those stem cells into heart cells or nerve cells. Kind of major scientific magic. So if you can do that, then you can study the behavior under a microscope or chemically about how the nerve cells of somebody with Timothy syndrome work. And you can treat those nerve cells with chemicals and drugs, figure out how to change them. So the fascinating thing about this science is the ability to get back at the cellular level to figure out how things work. It's extraordinary science. To get to this point has taken years and years of a whole lot of different basic scientists, but it's incredibly potent. If we kind of imagine what that means in 25 years, it means that we might be able to take a skin cell from somebody and understand how they are unique and different in a whole lot of different ways. And maybe even treat them. Stem cells are still on the frontier of therapy. We don't know how to use them very well, but it's quite possible that we're going to be able to do that. So here's some interesting ones. We're going to need some audio out of my computer. And let's see if we can get that. Close your ears. Nope. Up there in the booth. Help. What do you think? Oh, you know why? This isn't. The other end is not. Right, here we go. And this one, close your ears.
Johnny, hey Johnny, look, it's Teddy.
Crank it way up.
Play with Teddy? Teddy wants to play with you. Hi Teddy, how are you doing? Hey Teddy. Johnny, look, Teddy, can you say hi to Teddy? Teddy needs a hug. Give Teddy a hug. Teddy, do you want a hug? Teddy wants a hug.
This is very cool. I really want you to see this.
Johnny, hey Johnny, look, it's Teddy. Do you want to play with
No,
Teddy?
technology
Teddy wants
is
to
your
play with
friend.
you. Hi Teddy, how are you doing?
It doesn't like my computer. It's not a
Johnny, look,
Microsoft
Teddy, can you say hi to
computer.
Teddy? Teddy needs a hug.
It's because we're in Seattle.
Give Teddy a
If we were in California,
You want a
This would work much better. Sorry about that. Have to be a little funny. All right, let's try this. Let's see if we can do it from this microphone.
Johnny, hey Johnny, look, it's Teddy. Do you want to play with Teddy? Teddy wants to play with you. Hi Teddy, how are you doing? Yeah, Teddy.
This has actually worked here
Johnny,
before.
look. Teddy, can you say hi to Teddy? Teddy needs a hug. Give Teddy a hug. Teddy, do you want a hug? Teddy wants a hug. Teddy. Hi, Teddy.
Okay, we'll try that again. So let me first have you focus on this part of this picture. And what's happening here, don't focus on these other sections. What's happening here is that this figure, who's defined by lights on their body, is telling a story. This part is being played forward and upright. This part is playing time-wise backwards and upside down. Okay?
Johnny, hey Johnny, look, it's Teddy.
Can you hear that?
Do you want to play with Teddy? Teddy wants to play with you. Hi Teddy, how are you doing? Yeah, Teddy. Johnny, look, Teddy, can you say hi to Teddy? Teddy needs a hug. Give Teddy a hug. Teddy, do you want a hug? Teddy wants a hug. Teddy. Hi, Teddy.
Okay, so probably most of you understand the story that's being shared by those little moving dots, right? It's pretty straightforward. Your brain looked at those dots, listened to the sound, made a story out of it, made sense, okay? If you were looking at the, this side and you listened to that story, it wouldn't really make sense. Try it again.
Johnny, hey Johnny, look, it's Teddy. Do you want to play with Teddy? Teddy wants to play with you. Hi Teddy, how are you doing? Yeah, Teddy. Johnny, look, Teddy, can you say hi to Teddy? Teddy needs a hug. Give Teddy a
And
hug.
if you try and focus
Teddy,
your
do you want a
attention
hug?
here, I
Teddy
think
wants
you will
a
find
hug.
yourself looking here because that makes sense.
Hi.
Your brain's figured it out. The sound and the vision don't make sense here. They make sense here, okay? So when this same test was done with a number of different kinds of kids, typically developing toddlers, toddlers with autism in the upper right, and developmentally delayed toddlers, the little dots, the little crosses, show where the child was looking. That's how they did the research. So let's try and look at that again.
Johnny, hey Johnny, look, it's Teddy. Do you want to play with Teddy? Teddy wants to play with you. Hi Teddy, how are you doing? Yeah, Teddy.
So if you'll notice in the lower right corner, lower left corner, the typically developing toddler, these are pretty young children, are really spending most of their time looking at the figure that makes sense, right?
Hi.
They're spending most of the time in this story looking right here. They may glance over for moments here, figure out that it doesn't make any sense, I'm not going to look at that. So what happens with autistic children?
Hey Johnny.
Let's look in the
it's
upper
Teddy.
right
Do you
corner.
want to play with Teddy? Teddy wants to play with you. Hi Teddy, how are you doing? Yeah, Teddy. Johnny, look, Teddy, can you say hi to Teddy? Teddy needs a hug. Give Teddy a hug. Teddy, do you want a hug? Teddy wants a hug.
So I think you will see that the toddler, the autistic toddler, didn't know what to make sense out of. Spent one moment looking at the left-hand figure, back and forth, back and forth, back and forth. Confused. Similar children who are just specifically developmentally delayed did somewhere in between.
Hey Johnny.
They tended to be
Look,
less
it's
confused
Teddy. Do you want to play with Teddy?
than the
Teddy wants to
autistic
play with
kids.
you.
Okay, now we're going to move
Hi,
on
Teddy.
and do the same test
Johnny.
with a different
Hey,
story.
Johnny. Hey, can you see me? Hi. Let's play a game. Let's play patty cake. Ready? Patty cake, baker's man. Bake me a cake as fast as you can. Roll it and pat it and mark it with a B. Make me a cake for baby and me. Woohoo!
So would anyone volunteer to say what they saw differently? I'll play it one more time. Yeah. I'm sure that there's a way to do this. All right.
Hey, can you see me? Hi. Let's play a game. Let's play patty cake. Ready? Patty cake, baker's
Watch what happens to the toddler with autism
cake
when the figure claps.
as you can. Roll it and pat it and mark it with a B. Make me a cake for baby and me.
Now, there's nothing about this that tells you anything about diagnosis. Absolutely nothing. It is about trying to figure out ways to understand how brains work that we're after here. So what appears when you really look at the data from this is that it is the clap which orients the child to the correct picture. What are we going to do with that? I don't know. It's very, very basic science, but it's kind of describing some of the interesting ways that people are trying to understand how brains work, and particularly the brains of children that have autism. Sorry. So I was in France earlier this year and saw these signs on the street and thought I would share them with you. Save water, drink wine. Work, consume, be silent, and die. Are these any messages? I have no idea, but I thought they were fun signs. So more science. So we read papers that have graphs that look like this. And what this graph is a number of specific genes. They all have funny names. The ZNF451 gene and the REST gene and more genes, and how the proteins that these genes make are connected to each other or not. What systems they are involved with. Because these days we can identify the 30,000, 50,000, whatever the correct number of genes that we currently have. We have a lot of genes. And the vast majority of our genes have to do with our brains. Our brain is the organ that has the most DNA related to it of any of our organs in our body. It's not surprising. It's obviously our most complicated organ. So we need to have a biologic measurement to diagnose autism. We need to have a biologic measurement to diagnose autism. I'll say that about 100 times. Because right now, as I showed you before, it's a very confusing world. And so a lot of the research is directed at trying to figure out the biology of autism. So, gee, I'm running late as always. First, we spent a lot of time looking at genes. And I think I've already said this. We're starting to look at gene and protein networks. One of the more interesting things that just came out in the last few months is that the majority of new mutations, very small mutations, arise from the paternal side and not the maternal side. So for once, we can't blame the mothers. Of course, we always blame the mother. It's always the mother's fault, right? It's always the mother's fault. No, not always. And it's not a matter of fault. It's trying to understand. One of the things that has come up as around the world, childbearing has gotten to be older and older ages everywhere. 400 years ago, people were having babies at age 14. And now we're deferring childbearing until much older ages. Is there going to be a biologic consequence of that? Maybe. We don't know. This is very preliminary stuff. So it's not a matter of saying that if you are an older male who has just had a kid, it means that you're going to have a child with autism. It's just that this may be one of the mechanisms to help explain the increase in a whole lot of diseases. And the same stuff has been happening with age of mothers too, that as our germlines, our eggs and sperm get older, they accumulate more DNA errors. And these DNA errors may be responsible for disease. Is that why we have more breast cancer? Is that why we have more diabetes? We do. We have more diabetes. We have more breast cancer. Don't know. So again, what's the point of this? Well, maybe if we can figure out what these mechanisms are, we can actually start to have some effective treatments. And so this is important research. It's disturbing. It's confusing. But nevertheless, an important reality that the science is teaching us. And so maybe at some point, and there's a bunch of other research studies that I'm not going to quote here, about being able to look at the brain with MRI scan and a research fan. You can't make a diagnosis of autism by doing an MRI. Or looking at EEGs, or combining behavioral observations with EEGs, with genetic tests, with MRIs. We may have a more accurate way of describing people. And maybe we'll just have to take cells out of them and grow them in the laboratory and turn them into stem cells and test them to figure this out. But these are the frontier of understanding about autism. That's why I'm describing it to you. Science moves slowly. It doesn't mean we're going to have a treatment based on any of this stuff in the foreseeable future. But we will, eventually. So we're doing a lot of research here at Children's, just to highlight some of these things. Sarah Webb is doing the EEG studies and has demonstrated a normalization of EEG patterns following ABA therapies in a small number of kids. She's also looking at what the effects on the EEG normalizing to normal patterns following administration of a number of drugs. Rafe Bernier and Evan Eichler are studying genes. Brian King, my boss, studies a lot of drug effects. Gwen Glue, another of my colleagues, is studying Fragile X. Dr. Orlick, Felice Orlick, is studying things like peer support in high school students. I'm studying RNA markers, or I'm going to be starting a study of another kind of genetic study in the near future. And this is just a small sample. I've left off many, many people off this list. So there's a lot of research happening at the University of Washington, at Children's Hospital, University Washington Autism Center, and all over the country. But this is a major center for doing a whole lot of autism research, whether we're talking about how kids behave in school, or what kind of medicines we use, or some basic science kind of studies. That's good news. I give up. Oh yeah, so we're almost at the end. So what's nifty about autism is that it allows you to look at human beings from, you don't have copies of this slide, from a number of points of view. We could talk about the mind. The mind and the brain are not the same. The mind is much bigger than the brain. It's a concept. Or we can talk about DNA. Or we can talk about cells. Or we can talk about the brain as a whole. Or we could talk about society. Because all of these things are part of understanding what autism is and into the future. And what we really need to be talking about is the person. So now we're going to talk a little bit about local issues and what I've called insurance battles. Services for mental health are not provided equitably to all citizens. The events in Newtown, Connecticut should remind us all about how far behind we are in terms of dealing with people that have severe mental problems. Insurance companies have provided mental health services at a lower level of reimbursement and to a much more stringent extent than they have for medical services. Everybody's health policy, all of you have health policies, I'm assuming. You go and look at what the mental health benefit, it is much, much less than a medical benefit. Happily pay for a $5,000 MRI, about just about any body part for any reason, but not pay for a therapist visit. There have been some changes, some positive changes. There's been a long-standing Washington state law that requires that mental health services get reimbursed and are available at parity at the same level as medical services. That law was passed numbers of years ago. It hasn't changed anything yet. Insurance policies haven't changed, but the law is there. And on the basis of that law and other federal laws, there have been a series of landmark class action suits brought by parents against health providers, health plans, Medicaid predominantly, the big state health plan, Regents, Premera, Group Health, and they have been won. And they have been won on the basis of the Mental Health Parity Act that said that you can't discriminate, and a number of other legal arguments. So that as of January 1, some, but not all health plans are mandated to provide some kinds of mental health services to anybody with a diagnosis of autism with a medical necessity for those services. And then the specific kind of behavioral services that we think are quite beneficial are called ABA, or Applied Behavioral Analysis. It's generally been accepted to be one of the more effective ways to approach autism. That's not to say that speech therapy or occupational therapy or educational approaches aren't valid. They're equally valid. But this one is a very powerful one. And for the most part, citizens have been excluded from that benefit in this state because their insurance companies wouldn't pay for it, and it's very expensive. Other states, about 27 other states in the US, their legislature passed laws that mandated that their insurance companies that the state laws covered had to provide ABA. That has been brought up in the Washington state legislature for the last 5 years, longer, been defeated every single time by our legislature. So finally the citizens and a couple of brave lawyers took it in their own hands and forced the issue through the courts. So that's what's happening right now. We're going to have Autism 200 talk specifically about this, so I'm not going to be able to go in depth. When is that, Jim? March. So if this is a particular burning issue for you, come back in March and we'll try and explain it. It's really very complicated. It's very important. It's certainly one of the most important increases in services that I've seen in many, many years based on these cases. And it's still going to keep changing. So it's going to be very confusing for families and providers alike. So I think I've said this already. This is an old slide. The Department of Social and Health Services that manages Medicaid has actually been remarkably helpful, very positive, much more so than the private insurance companies who continue to challenge these cases with another court battle after another court battle, as insurance companies are wont to do. But the state has decided those people that are on state insurance, two insurance categories, state employees who get what's called the Public Employee Benefit Board programs that are state employees, which is the largest insured group in Washington State. And children that receive Medicaid will now have ABA services paid for. If there are enough therapists, which there are not, if there's, if. So it's going to take a while before this new benefit gets rolled out to the larger population. But it's a huge advance. Let me see. I think I said this already, and I'm not going to go into the details because it's complicated. There's certainly more work to do. To get an ABA prescription written requires that you be seen at what's being called by the Department of Social and Health Services a center of excellence. They haven't yet defined centers of excellence. There is no center of excellence, to my knowledge, in Moses Lake, in Othello, in Longview, and right now it's Children's, the University of Washington, Yakima Children's Village, maybe someplace in Wenatchee, Mary Bridge Hospital in Tacoma, but certainly doesn't cover the whole state. So it's very much a work in progress, and we're trying to sort out what that means. There's not enough, state currently doesn't license people who are board certified behavior analysts, BCBAs. There's no category of licensure in our state. The Department of Health, which regulates licensure, has refused to create a category. Though there, frankly, you know, there's licensure for acupuncturists and aromatherapists and you name it. Many specialties, but they haven't been willing to, so far, license BCBAs as its own category, which is one of the barriers to having people available to do that service in Washington State. We're getting a new Secretary of Health with the new governor, so things may change. We don't know yet. Very much a work in progress. I'll tell you a little bit about our place. The Seattle Children's Autism Center, which I'm very proud to be affiliated with. We're a pretty new organization. We opened in August 2009. We do a whole lot of different things. We do diagnoses and short-term therapy, family support, medical evaluations. We have an adult transition program. We do a lot of advocacy and legal work around the state, training of providers, and do a lot of work of trying to support communities. I'm going to Longview in a few weeks to help them set up a center of excellence. So we do a lot of stuff, and we're quite proud to be doing that. Last year we saw 18,200 patient visits. When we opened our doors, we had 500 people on our waiting list and saw 300 patient visits a month. We're now seeing 2,200 patient visits a month. The more patients we see, the longer our wait list gets. We've maxed our physical space in our building, which is a few blocks from here, separate from the campus. And so we are struggling to keep up with the load of stuff that we are committed to doing. So if any of you are here on some kind of waiting list, I apologize profusely. We're doing the best we can, working as fast as we can. We have tripled the size of our faculty. We're now probably one of the biggest autism centers in the USA. Here's a small list of some of the people, and this is not a complete list, of some of the people at work. And what we're quite proud of is the fact that we have people from a variety of disciplines: psychologists, pediatricians, neurologists, psychiatrists, speech therapists, family support, which is a key component of our program. We're very proud to have Lynn and Katrina working hard. Nursing, nurse practitioners, a huge administrative staff. And last year, we lost $1.1 million, despite the fact of seeing 18,200 patients. We're not so popular with the hospital. Nevertheless, they're supporting us. They support us emphatically, even though we lose money. We're not cardiac surgeons. That's where you make money in medicine these days. So we're very pleased to be part of this organization that is committed to seeing anybody in any circumstance as best we can without not considering the ability to pay. There's a consequence for us because we lose a lot of money every year. So we're always asking, we're always trying to fundraise and go beg and sell cookies on the corner or something. We haven't quite gotten to the point of doing car washes yet, but maybe someday. It's hard to get $1 million out of car washes, but anyway, I'm not begging here. I'm just saying that it's a dilemma for us as well as all the other organizations around the state that are struggling with trying to provide services. We're under-reimbursed. We work very hard, and there's a long waiting list. So another really good issue that's happening in the state is what's called the Washington Autism Advisory Council. Numbers of us have been meeting every quarter for about 5 years. All the people that are interested in autism around the state, people that are advocates, people that are therapists, people that are providers, parents, to discuss various issues about autism. We have one of the most active in the US big autism councils, and we're very pleased, and that has resulted in a lot of really wonderful work. The WAC, the Autism, we call it the WAC, the Autism Advocacy Advisory Council created this paradigm to take to communities, trying to identify people in a community that would kind of be able to provide services at different levels of this pyramid, starting from just being aware, having the public be aware about child development issues, and increase in early screening, because early diagnosis is very important, and moving on up. And this is the kind of way of thinking that we're trying to develop services in a diverse set of communities, using a process called community asset mapping, getting together all the stakeholders in a community that are interested in autism and having them start to work together. People in different disciplines don't talk to each other. School people don't talk to medical people often enough, or to mental health people. And so to bridge those silos of ways of doing things is really a very difficult job. Getting people all around the table to talk about this, I have a group that I meet with on Whidbey Island that's gotten school district personnel and healthcare providers and speech therapists sit around and talk about how to provide services in that community. It's a very important way of doing things. We're very, very proud of that. This is where projects are currently going on, CAM projects, community asset mapping. And we're just going to start one down here in Cowlitz. That's where Longview is. Notice that lots of parts of the state don't have this. Certainly also, but where the big populations are, King, Pierce, Snohomish County, Tacoma, Everett, Seattle, do not have this kind of project going. They have other resources, but not this kind of project. So there's a lot of work left to do. So when we look at how this impacts people in different parts of the state, these are data that I put together a few years ago, looking at the rate of autism diagnosis as registered within school district information. So when children have a specific diagnosis, there's a form that's filled out, they have a category of special education or disability, and you compare the population of those counties to the number of counted individuals, and you come up with a rate. So one of the things to say is, at least for young children, that rate, which ought to be at 90, if that's the ideal number, or 100, is here. Some counties don't have anybody identified. Some counties have a lot. Look at Kitsap County.
What's happening there?
What's happening there is very interesting. Bremerton has a big Navy population. There's a naval hospital in Bremerton with one developmental pediatrician. And military personnel, if they have a diagnosis of autism, get ABA services as part of a military healthcare benefit. So there are kind of incentives to get early diagnosis because of that unique event. Either that or something is very strange happening in Kitsap County. Maybe it's the radiation from Bangor. Probably not. But I mean, when we see these kind of patterns, it's really very confusing. It's really, really very confusing. Sometimes there's an explanation, sometimes there's not. So when we look at older ages, the numbers get bigger. So by the time you get between 6 and 21, we're identifying children to a higher degree, but a lot of variation from county to county. Again, Kitsap is one of the biggest. And if the ideal is up here, we haven't identified anywhere near the number of people. That means that kids aren't getting services. They're not being diagnosed. Now, these are old data. There's like 3 or 4 years old, so I haven't looked at it recently. So it might have changed. And I want to leave some time for questions, so I'm going to just rip through these last few slides. You want to know something about treatment. Oh, by the way, this is James. James do those dancing numbers. And the other thing that James does as an artist is that the repetitive quality to his art is that he has many pictures that show people with increasing sizes, with numbers on them, fabulous hair and fabulous shoes. Okay? Fabulous. You think any of you could draw that on a computer? Could you do that at age 5? It's wonderful. Wonderful. I want to leave time for questions. Just to say that one of the approaches to treating autism is what's called the Early Start Denver model, which is kind of an ABA, an intensive ABA approach. And there was a research study that was done here in Seattle with a very small number of kids. I think there were 24 enrolled in this study. And they did intensive services for a whole 2 years. 2 years. And then they looked at IQ changes and compared them to a community group. ESDM is the intensive group. This is the community group. These are IQ scores. And these are scores of adaptive functioning, how well you can function. And these scores demonstrate that this intervention, expensive, high cost, that's the same thing, expensive and high cost, and intensive, does seem to result in better improvement and better improvement in function compared to a control group. The same group of kids, by the way, has now been studied with the same approach with EEG studies and has shown in a paper that was just published recently a normalization, moving toward a normal pattern of EEGs. So this is some evidence that maybe this intensive therapy actually changes brains, improves function. Still very preliminary, but this is what we hope. And this is the excitement about ABA. This is why potentially ABA is going to improve outcome. Still very preliminary, a lot of hurdles, but it's exciting. I don't want to do this one. So last, I'll show you another picture of James, my favorite artist. So sidewalk chalk, age 5. Check it out. Delaware's there. Delaware. Do you remember where Delaware is? Rhode Island. He's got everyone. And you know what this, there's Alaska and there's Hawaii, because those of you that remember your childhood, this is that puzzle that we all had, right? That wooden puzzle with all those pieces of different states We put them together, but he's got them memorized. He can do that straight from memory. He wasn't looking at his puzzle when he drew that with sidewalk chalk. He just went there and drew it. Okay, I'm done. Questions, comments, anyone? And Jim's wandering with a microphone because when you make a comment, the folks in Yakima can't hear you unless you talk into the microphone. And then there'll be some time for our community out there. Again, I apologize for trying to cover a lot of material because autism is a very broad topic, just touching on a whole bunch of different areas. No one has any questions. Anyone from far away want to turn your microphones on and ask any questions? Or are you all exhausted by all of this stuff? Yes?
I don't know if it's really a question or more of a clarification.
Yeah.
But under more science, you mentioned the different areas that everybody was studying, the EEG, the genetic studying with protein networks, and Brian King was doing something on autistic kids with drugs.
Yeah.
Everyone's kind of doing their own little research study. Do you guys ever work together to?
Oh yeah. I mean, this is a bad way of describing it, but what I was attempting to show is that people with different kind of scientific abilities, if you are a gene jockey, as we call them, somebody that sits in the lab and tears apart genes, that's what you know, that's what you were trained to do. You're going to make a contribution about genetics. Somebody that, like Dr. King, that understands psychopharmacology and how drugs work in the brain is going to work on that. We all relate to each other. We all talk to each other in different ways. But this is a problem that's got to be approached from 100 different points of view. We need to understand how to treat kids in schools. We need to understand what therapy, what ABA does and doesn't do. We need to understand how the brain works. We need to understand why things happen. Is there something in the environment causing this? We need to do them all. And so all of these folks are doing things because they have particular expertise in them, but they also know about all these other things. And generally, these kind of research studies involve many people with different skills. For instance, if you're going to do a genetic study, you need a partner who is a psychologist who can identify and describe the patient population that you're going to do genes about. So yes, people do work together, sometimes a lot in their own silos, you know, in their own ways of doing things, but that's kind of the way science works, that there are many, many approaches. And as I showed you in those intersecting bubbles, you know, you got to study the mind, you got to study the DNA, you got to study the brain, you got to study the cells, you got to look at society, you got to look at the whole person, because they're all important.
So one add-on to that, Dr. Cowan. So given all the stuff that you know, the research that's going on nationwide, and the state of the affairs as you've discussed today, how far along do you think we are in finding some progress or a quote-unquote cure?
Well, I wish I could say that we've moved along very fast. There's an organization called IMFAR, or INSAR, International Society for Autism Research. It's all the people around the world. And they meet once a year. And I've been going to these meetings now for 11 years. And the level of sophistication of the science has increased, but it's still very much basic science. If we look at the analogy of cancer and how long it took to move from every child with leukemia dying to only 10% of kids with leukemia dying, it took 50 years. And the brain is much harder than the bone marrow. On the other hand, the science keeps accelerating. It's like, you know, the rate of computer chips. The amount of new knowledge, as I showed you in that first graph, is growing almost exponentially. It's so hard to keep up with it. So that's good. The problem is huge. The interest in it and the tools that we have to study it are much more powerful than they were. So I think that our rate of learning about this is not going to be as slow as leukemia. But I don't know. I was at a meeting 2 years ago with some colleagues, and I asked the question of the group, how long would you think it would be before we can cure autism? And the answers were never. Some people said that. Some people said 100 years. Some people said, I don't know. I said 25. I made that number up. There's no way to know. All I can say is that we can look at the trajectory of increase in understanding of how the brain works, which has been astronomical in the tools that we have, versus how hard the problem is. Brain is not an organ like the blood that you can take out and look at under a microscope. And we can understand how the heart works and the kidneys and the liver so much easier than we can learn how the brain works and why it works in its curiously different ways in some situations. So it's a really hard problem, and we have really much better tools. And I think we're going to be able to have enormous progress, but it's going to take time. It's going to happen in the lives of our children. I'm very much an optimist about this, but I don't know when. And there are many barriers along the way, including our U.S. Congress deciding that research is phooey, and we're not going to fund it anymore because we need to get more guns or something. So that's the real problem. We're not going to have this research if the Congress doesn't allocate money for it. Yes?
Going clear back towards the beginning when you said you were moving from the triad to the dyad and acknowledging that social and communication is so intimately linked, what type of research is being done into autistic and deaf children?
Oh, it's a great question. Very little. Very little, I would say. Big gap in, I haven't seen very many papers about that. Children who are deaf or children who are blind have at times autistic phenomena. Certainly if you can't hear, it impacts your ability to communicate.
My nephew is 9 and was just diagnosed at the center in Seattle as autistic.
Yeah. Probably 10-15% of children who are deaf have symptoms that look like autism. Flip side, why do 85-90% of deaf kids who are faced with the same issues are not? Don't know. But unfortunately, I don't know of any focused research on that particular question. But again, if you looked at the number of articles there are about autism, I'd have to do a Google search on autism and deafness to get an answer for you, and I haven't done that recently. I know, we're all tired. It's late. We'll have maybe one more question, and then I'll hang around if you're too embarrassed to ask your questions to the grand public. Yes. Are there somebody out there in space that has a question?
Yeah, can you hear me?
Yes.
Yeah, so I'm a mother of a 5-year-old, and I'm trying to make some decisions for his educational future. I'm sorry, I'm getting a lot of feedback from this microphone. Okay. So I'm interested in your opinion on the ABA versus public school. When my son goes to public school, he seems to lose his regulation completely. We've done a little bit of ABA, but because of money, we haven't done it in any kind of a intensive way. But I'm trying to seek advice on where to go for him.
Okay. Well, I would never I would not pose that question as an either or. I would pose it as an and. Because ABA is an adult-to-child intervention, and school is a child-to-child intervention. So autistic children that have trouble understanding social behavior need to be around kids. It's critically important. In fact, there was one of the what was called the top research studies of 2012, according to Autism Speaks, was a very nice study that was done in California that looked at two separate interventions for school-age kids. One that involved teaching kids social behaviors by a teacher, and one that recruited peers, 3 peers per kid, to teach them social behavior. And they were looking at time spent alone on the playground, number of friends, and a number of other things. And the peer approach worked better than the adult approach. So I don't think it's an either or, I think it's an and. That children that have autism need to learn communication skills, social behaviors, adaptive skills like how to take care of yourself in a number of different settings with a number of different kinds of models and teachers. They need a lot of teachers. Their parents are their teachers, their school teachers are their teachers, their therapists are their teachers, their grandma are their teachers, because they need to learn from a whole lot of different sources. And peers are incredibly important in that learning. So I think school is very valuable. The challenge is putting it all together, making all of those different therapies work for a child, having everybody cooperate on the same page, working on similar issues. And that is not easy. Parents are the team leaders of this effort. It's a really hard thing to do, but it's kind of getting all your therapists and everybody to talk to each other, and you and your child are in the center of that. And to some extent we can help that, to some extent we can't, but that's a really important principle. I think there was a question. Yes. You have the microphone.
Sorry, I just had a final question about if any research studies are being done around the effects of having food sensitivities and allergies and chemical sensitivities and immune issues and autoimmune. I mean, our whole family, my father has Asperger's, was just diagnosed in his early 60s. My brother recently decided he does too. We've always known. His sister, half our family's bipolar. Our child has autism. We all have horrific food intolerances, chemical sensitivities, off the charts. Is that study being done as well?
Yeah, there's actually a lot of interest in the immune system. Not, I wouldn't say necessarily specifically about food allergies, but how the GI tract deals with. There's a lot of GI stuff associated with autism. There was an interesting study that was done in mice, because you could identify an autistic mouse, which you probably didn't realize, but there are autistic mice. Autistic mice don't like going into a chamber with a new mouse. That's their social problem. And they don't make as many noises, so they don't speak as much. And the study involved messing with their immune system during the mouse's pregnancy, and that increased the amount of autistic behavior that those offspring displayed. And so there is some questions about how the immune system interacts with this. There's also a fair amount of observation that genetic markers for autoimmune disorders like lupus and rheumatoid arthritis and a couple of other immune disorders are closely associated with known autism genes. So that maybe if there's so we don't know, but it's an active area of research. Yes, it's an active area. We don't understand it yet. It's very confusing, but it's a real phenomena. And then it's a matter of, is this a causation or an association? The two happen to go hand in hand, and one doesn't cause the other, or is one causative? Those are hard questions to answer. One more.
Thank you. So I'm curious, you talked about diagnosed. He's way behind in school. He's 8 years old. And in my opinion, he's not paying attention. He's not present. And so there's obviously some sensory something going on that's keeping him from.
Well, the answer is maybe. The reason why sensory isn't included as a specific domain is that sensory differences happen in a lot of developmental disorders, not just autism. They happen in ADHD to almost the same degree. They happen in children with intellectual disability. They're not specific and unique. And the sensory system is extraordinarily hard to study because no one can know what somebody feels, smells, sees, or hears. We can know what you do. We can know output from the brain. I move my hand. That's coming from my brain. I'm talking to you. That's coming from my brain. That's output. What's going in to my brain is a complete black box. We have no idea. No way to measure it. Not totally. And how all those things interact, the explanation that some therapists say that the cause of autism is because of sensory processing problems is missing the point. It's much more than that. It is a set of symptoms that is seen in association with autism, but not necessarily a cause. And there are many issues related to why people pay attention, not just sensory stuff, but stuff in the frontal lobe called executive functioning, how you make decisions that have to do with this part of the brain. And this part of the brain is well known to have some abnormalities in white matter tracts in autism, as we've recently learned with some sophisticated MRI studies. So it's always much more complicated than one thing. That doesn't mean that you can't treat it. That doesn't mean that you can't pay attention to it or acknowledge that it's an important problem, because if somebody is paying attention to what their sock feels like instead of listening to their teacher, and if the sensation of their sock is at the same level in their brain as their teacher's voice, whoa, it'd be pretty darn confusing. But how we deal with that, what treats it, what affects, don't know. Another area of much research. Okay, thank you all for your attention. Appreciate it.